A heartiest good evening to one and all. I welcome you all to yet another discussion on the Breast Cancer Action Month, an initiative of Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance being powered by Novartis. For this discussion, which is part of the breast cancer awareness series that we are doing, the discussion is on the topic of breaking down barriers, ensuring equity in breast cancer care. And to deliberate in detail, we have a very eminent set of panelists here with us today. I welcome Dr. Lalit Kumar, who is Chairperson of Oncology and BMT at Artemis Hospital, Gurugram. So, welcome to the show. Thank you so much for joining.
Thank you so much.
We are joined by Ms. Shilpa Arora, who is co-founder and COO of Insurance Samadhan. Ma'am, thank you so much for joining.
Thank you, Doctor.
We are also joined by Dr. Dibjyoti Das, who is the head of medical operations and planning with Assam Cancer Care Foundation. So thank you so much for joining.
Thank you, Dr. Asawari.
We would also be joined by Dr. Urvashi Prasad, who is Director for the Office of Vice Chairman at Niti Aayog, and would also be joined by Mr. Ajay Vaze, who is Chief of Strategic Initiatives and Partnerships with Arogya Finance. So let us start with our discussion. So as the discussion topic is on breaking down barriers and ensuring equity when it comes to breast cancer care, I would like to inform first to all our audience what equity in healthcare means. It's the quality of being fair and impractical. That is, for somebody who needs more care, the more care provisions are available for them, and somebody with less care needs, less provisions are available for them. So that is equity when it comes to healthcare. My first question is to Dr. Lalit Kumar. Sir, in the cancer care space, as you know, there are various factors that impact the overall treatment outcome of a patient, not just a medical care, but also other factors such as access to care, availability of treatment options, availability of healthcare infrastructures in their city, funding, insurance support, location, whether they are urban or rural. All these factors also come into play majorly, especially in cancer. So can you please talk about these factors, how much weightage do these play in patients' cancer care journey?
Okay, very nice. Actually, in general, like if we say like having timely diagnosis, so and starting treatment in time, not really, and using standard protocols, the treatment protocols for that particular disease, which have been accepted by the international community, and availability of the drugs, and going through the treatment, and then subsequently a good follow-up. These are the common key points for a successful outcome for any chronic disease, like particularly the malignancy, like the breast cancer, which we are talking. Now, coming to the timely diagnosis, like obviously the distance the patient where he lives, like rural area or rural, poor urban areas, going to a bigger center where the facilities are available. And as we know that in India, we have still very few, there are still very few centers, especially in the rural areas, where the people do not have access like up to 100 miles or 200 kilometers from their place of stay. So going to such a long distance obviously is a problem. And then initially till the diagnosis is made, it may take like couple of trips, or you have to stay there. So those kind of expenditure, and so all those things do affect. Then once the diagnosis is made, then sometimes there is a delay in the treatment also, couple of weeks, and then the discussion about the treatment aspect comes. So where the funding part comes, like, so many government hospitals may have the provision for the subsidized medicines or free medicines, but not all the hospital will have that. So obviously for the people who cannot afford, who do not have the insurance or access to some of these kind of, then how do they really cope up? That becomes one of the problem.
Thank you so much, Dr. Lalit. We will come back to you, sir, for more such inputs from your experience. Let me ask the next question to Ms. Shilpa. So, ma'am, you are representing Insurance Samadhan organization. Can you please highlight a little bit what the organization works in and how the organization is supporting individuals, especially in cancer care space?
So Insurance Samadhan was founded about 5 years back, and we are trying to help people who are facing health claim rejection or there is a delay in settlement. During this journey, we also realized that people are not aware of their pre and post reimbursement filing as well. So we have developed an app called Polyfix, which will help the policy holder to understand what kind of policy are they holding, what is the sum assured coverage, and they can also file their pre post reimbursement. We have also seen that once the cashless claim is rejected, people feel that this is the final rejection. They do not understand that they have to file a reimbursement with the company. And then the rejection comes, and that is the final rejection. So people fail in the hospital only after receiving the cashless claim. They don't go ahead, and they don't know, and they are not aware. So we are trying to create that awareness, and we are also helping the patients across all segments. Coming particularly to cancer, recently my mother is on 2nd October has been diagnosed with stage 4 of cancer, and I am personally experiencing a lot of issues. There is a cost involved, a very high cost, which I think is very difficult for people to afford if they don't have a medical insurance. And by medical insurance means you need to have a very good coverage. A recent study suggested that 5 lakh is sufficient, but I feel with problem like a cancer, fighting cancer, you need to have at least a 20 to 30 lakhs or even more, whatever highest coverage you can, you must buy, especially in the metros. And then city wise, there has to be, an awareness on how much medical insurance is required. I have also faced issues personally also, and we also get patients where modern therapies are not are rejected. If the doctor is using the latest technology, robotic surgeries are rejected, which should not happen, because there are clear guidelines by IRDA that these needs to be paid. So doctors are also not able to offer modern therapies and these robotic surgeries, just because they feel that the cost to the patient will increase and it will not be covered. So when I spoke to Dr. Kataria in Medanta, where my mother is getting treated, so she was also of the opinion that CyberKnife, if I opt for that, it will not be paid through, because it comes under robotic surgery. But then they paid, they paid the claim. So it is about the awareness also, and how patient needs to represent their case to the company and then to the IRDA that these claims needs to be paid. So
Thank you
that's
so much, ma'am. You brought to light some very, real experiences and scenarios through your experience, unfortunately, as well as what you have been seeing in your practice with the organization. So, as we all know, that literacy around health insurance aspect or insurance or money management in general in the entire country is not so much. If you are not from insurance background or you're not from banking background, people usually are not really aware. And the same goes for healthcare clinicians as well. So some of the insurance organizations say that these treatments are supported, some are not. But for the buyers or for the consumers, when the time comes to utilizing such services, they get to know that okay, these all treatments are not covered when the treatment is really recommended maybe for their case. So why do you feel that this is the case? Should the government look into it? As we will be having Dr. Urvashi as well from the government's aspect, so we can ask her these queries, that why are only some services are supported or some are eliminated? What is the logic around, if you can help us understand? Michelle.
So there are guidelines by IRD where modern therapies are covered, and also robotic surgeries are covered, but there may be a capping depending on the insurance policy that you have taken. So we need to see the insurance policy and then see the coverages. Coverages are there. Maybe the hospitals are not aware that we have to represent it as a robotic surgery or a modern therapy, and which regulation covers that. And if we raise it to the company with the regulation, they immediately pay. I have seen oral therapies also being rejected and then later paid, because these are also very costly. Even the oral chemo is very costly, and these are getting rejected. And when we represent through the regulation, they are getting paid. So it's the companies are trying to reject. It's just that you need to tell them that this is the regulation under which they are covered, and they immediately then try to pay.
Okay, yes. So awareness and literacy around the entire health insurance aspect is still not quite there, that we need to look into. Before more questions from you, we have Dr. Dibjyoti Das as well with us. My next question is directed towards him. So sir, as we are discussing the equity space around cancer and breast cancer specifically, Assam Cancer Care Foundation also works in this space. So can you please highlight how the organization is helping for women in breast cancer, or for so many people that are facing cancer, to provide equity in their care journey?
Thanks, Dr. Asawari, for the question. So, Assam Cancer Care Foundation actually is a joint initiative between Tata Trust and the government of Assam. It's a Section 8 company, not-for-profit company, wherein we have actually plans to set up 18 hospitals across Northeast India, 18 cancer hospitals across Northeast India. And currently we have operationalized 7 of them. So basically our Assam Cancer Care Foundation works under the model of distributed cancer care, wherein we are having 4 tiers of actually cancer care. We have got level 1 institution that is in Guwahati, which is like the epic center, which will not only be catering to the various type of cancer treatment, but also will be taking care of academics, because that is a very integral part. Then next we have level 2 hospitals. Right now we are having 2 of our hospitals which comes under level 2 category. So level 2 hospitals are typically around 180 to 200 bedded. So they have got all the modern facilities, starting from LINAC to your chemotherapy, then brachytherapy, then surgeries, etc. But it is having limitations in terms of not having maybe robotics, etc., which is now limited only to level 1 cancer care in Guwahati. But it also has got something like PET-CT also, which we have incorporated in level 2 tier setup also. And next comes the level 3 setup, which consists of mainly 45 bedded hospitals. Currently, we are having 5 such hospitals across Assam. And this level 3 hospitals usually cater to your patients mainly on daycare needs, daycare requirements, like radiation patients, or maybe patients who require chemotherapy and can go back to their homes, and also some sort of small surgeries like biopsies, etc., that we usually do in level 3 setups. Other than these 3 level of setups, which are basically based with respect to healthcare delivery, we also have got a level 4, which includes mainly outreach teams. So we have got a huge outreach team spread across 10 districts, wherein we have got doctors, nurses, etc., which do a lot of screening actually programs. So till now, in the last 1 year, we have done more than 2 lakh of screening. Specifically, we are targeting on 3 main cancers, that is cervical, oral, and breast cancer. Because as you all know, that breast and this all 3 cancers are having very high incidence in our this northeastern India, and at the same time it's very easy to actually screen this type of cancer. Specifically breast cancer is very easy to screen, so that's why we're focusing on these 3 cancers right now. So this is a typical model of Assam Cancer Care Foundation, and we are actually we have done a lot of tie-ups with government schemes, with insurance companies also. Right now we are having tie-ups with 18 such insurance companies, and also with government schemes like Pradhan Mantri Jan Arogya Yojana and Atal Amrit Yojana. And at the same time, we're also taking help of some donors, because what we have realized is that just mere actually support in terms of medical care is not enough. We have seen that patients face a lot of problems in terms of their non-medical expenses, the indirect expenses, which is a major cost. We have even seen patients who are actually getting free treatment through maybe some of the government schemes, but still they were not able to come to the hospital because they don't have enough money actually to bear the traveling cost. So those were some of the challenges that we saw actually. And what we did is we did tie-ups with some of the donors who were ready to actually fund for things like maybe travel costs or maybe accommodation, etc. Because again, as you know, patients like radiation, etc., need to stay for 35 cycles together at a place. So all those are some of the challenges that we are trying to actually intervene through various means, through various collaborations, etc. right now. Yeah.
Thank you so much, Dr. Das. We will come back to you for more queries. But before that, I will take my next question from Dr. Urvashi, who has joined us. Dr. Urvashi, ma'am, welcome to the show. Thank you so much for joining. If you are here with us, can I take the question from you?
Yeah, I'm here. I'm in the car. So sorry, there'll be some disturbance, but go ahead. Yeah.
So, ma'am, we are discussing the very important topic of ensuring equity in breast cancer care. So, when it comes to cancer overall, can you please share some of the initiatives that the government has undertaken to help people when it comes to cancer care, and also providing equitable access to cancer care for people who need it the most?
Yeah, so, cancer care obviously is a very broad subject, and, one could talk about it for a very long time. So I'll just summarize very briefly, what some of the key areas of focus have been. So I think, one obviously is the whole, promotion of healthy lifestyles and prevention, because, we always know that prevention is better than cure. And so, especially when it comes to something like cancer, as much as possible, we have to try and prevent it, and therefore, helping people avoid the risk factors, the proven risk factors like tobacco, or, just helping them live generally healthy lifestyles. That is something which, is one big area of kind of policy focus when it comes to cancer care. The second, obviously, is screening and early detection, because we do know that if we can't prevent, then early detection is the next best, that we can do. Because, most of the cancers, unfortunately, still in our country, they are diagnosed at stage 3 or stage 4. When it is much more complex to treat them, it is much more expensive to treat them. So we really need to, and obviously the survival rates are not so good as well, by the time the cancer has already metastatized or spread. So I think, the screening and early detection, and I think especially when it comes to breast cancer, this is very important. And we obviously have to look at low cost, methods of screening. We have to look at promoting, self-breast examination amongst younger women. We have to look at especially screening women who have a family history or, who are high risk. in some form or the other. So I think that is something which is the next kind of big bucket of policy focus. And then of course it comes to the actual treatment part, and I think when it comes to treatment, we have to look at it very holistically, because I am myself, as you know, I am myself a stage 4 cancer, survivor, patient, whatever you want to call it. And, I need not just physical support, but, you need mental support, you need psychosocial support. So I think we need to really broaden that definition of, cancer care, treatment, in the way we look at it. We need to have suitable policies and programs, for all of this. We need to integrate with, civil society. We need to integrate with communities, so that, because there's still a lot of taboo, stigma, associated with cancer. There's a lot of fears and myths and misconceptions. So, all of that the government can't do alone, so we have to work with other partners. We have to work with civil society. We have to work with other stakeholders. But the point I'm trying to make is that we must broaden out this whole definition of cancer care to just, it's not just chemotherapy, radiation, or targeted therapy or surgery, right? That is, of course, very crucial. We need to come in with measures like insurance. We need to start covering for, better and newer treatments, which might not be covered by insurance today. So, of course, we need to do that. We need to make treatment accessible for the poor. So I think those are, completely priorities. But I think as a conceptual level, and as also as a patient or a survivor myself, I think that broadening the definition of cancer care, looking at the psychosocial aspects, looking at the psychological aspects is very important, because, ultimately cancer takes a huge toll on a patient's life, which goes, well beyond the physical kind of impact of it. So I think that is a direction that, I would really emphasize.
Thank you so much, ma'am, and thank you so much for pointing out the very real experiences and situations that people might be suffering from, and your, personal experience also. Thank you so much. I will come back to you to know more. We would want to know more about few aspects, but I will take my next question from Mr. Ajay. So, Mr. Ajay Vaze is the Chief Strategic Initiatives and Partnerships for Arogya Finance. Thank you so much for joining. We would like to know more about how Arogya Finance is working in this space of cancer care, also specifically in breast cancer, if you are, as it is a social healthcare financing organization, which offers medical loans to people in and outside of the formal banking system. So how can people, be made more aware of this, of all the good work that you have been doing, and also the benefits that they can avail?
Yeah, so Arogya is a fintech. We are a non-banking finance company, and we have like 4 care options for cancer patients and their family members. So we work with our first solution, which is called as a Care Now Pay Later. It's short form is CNPL. So CNPL is a business to consumer model, and our fintech solutions are like taking care of this digital onboarding, automated rule engine based approvals, touchless documentation and disbursements. And though we work in oncology space, we work with one of the highest approval rates. Our overall approval rate is around 80% in the space. Our second product is socio-economic evaluation. We carry out socio-economic evaluation of family members of these patients, and basis these evaluations, we work with our partners to arrive at a affordable pricing for expensive medicines. And we are working in oncology space for this genomic test also, because of which some of these high cost medicines and tests become affordable to the patients. Our third product is bridge finance for non-cashless claims, because some of the breast cancer patients, oncology patients, they avail non-cashless treatment at the hospitals, and through us they get a seamless journey, because we make the payment to the hospital's account and the patient pays back to us when the insurance claim is settled. So this is the space so like we have started working over for last 1.5 years, and here we are working with our insurtech partners so that the journey for these breast cancer patients should be as seamless as possible. It's just so like digital sanction which happens at the time of admission to the hospital, and the payment is also seamless. In addition to that, we have a product called as Arogya card, which provides a limit of up to 10 lakh rupees to the card holder, and with this they can select avail the limit for the 4 dependent family members. So many of these innovative models we have developed, and we cover the entire age group of the people. We finance up to 65 years of age patients as against an industry norm of 58 years. So all these solutions are available. What we need is a small support from like institutions like Niti Aayog, etc., so that if we are introduced to maximum number of families and healthcare partners, these services can be extended. Currently, we are working with 2,400 plus partners. This can be made select to more number of patients and users.
Thank you so much, Mr. Ajay. We will come back to you for more specifications on the same. Thank you so much for sharing. But before that, we have one question for Dr. Lalit. So, sir, as Dr. Urvashi was saying, that we need to broaden out our definition of the care that we give for cancer. And I am sure in your experience also you have you have identified many such gaps that, people face in the cancer care journey. So can you please talk a little bit about that, and how can, clinicians, not only just clinicians, but overall the society together can help support, all the different aspects that the care is required around cancer. Sir, if you can please unmute. Yes. Yes.
So, very important point. So let me just first tell you from the breast cancer perspective, there are 3 or 4 important differences which we see in India for the breast cancer patients. One, that the incidence of breast cancer in our country for is still lower than what we see in the Western world. So like somewhere about nearly 30 to 35 per 100,000 compared to 90 to 120 in the like North America or Nordic countries, where this incidence is very high. The other important point that age is like almost 1 decade younger. We have the median age of 45 to 47 years compared to like 55 to 58 years in the US. And thirdly, the higher stage, that is almost 60% of our breast cancer patients come in the stage 3 and stage 4 compared to 20%, 25% in the Western world. So, and as a result, almost 25% of these patients would have the so-called very, very aggressive subtype of breast cancer, like we call them triple negative breast cancer, TNBC. So these are some of the points. Now the question is like how we can really improve the access to these patients. Like so, obviously the first point would be like if we can bring them to early stage when the results are better, stage 1 and 2. So the most important would be like the educating the increasing the awareness of the patients, their family caregivers, family members, and even the health professionals. Like as Dr. Dibyajyoti said, that they are doing the screening for the cervical, oral, and breast cancer, because these all 3 cancers are amenable. And the government of India, I think 2016, launched a program, and where they trained a lot of ASA workers in the more than 450 districts to really examine the population, and because of COVID, this got little got stalled, but I think they may be probably starting again. So that kind of program can be started. So if the women can be encouraged to do the self-examination, they can be made aware that these are some of the initial signs of breast cancer. And once in 2 years, if they can be examined by a health professional, like ASA worker or some community health worker, or primary health center, then there is now data which was done like a randomized trial a few years back and published. And they have shown very clearly that if you can reduce the mortality by 15% by bringing them into the stage 1 and stage 2. So that is the some very important and long term. I think that is the most important thing, I would say, to bring them to the early stage. And secondly, the making a standard diagnosis. Unfortunately, in India, we still have patients coming with the diagnosis of breast cancer. Sometimes the diagnosis is not really up to the mark. So, and you need the basically 3 basic things like the estrogen receptor, progesterone receptor, and HER2/neu. These are the 3 basic aspects of the breast cancer where the treatment is dependent on them. So many times we don't really have. ICMR about 3 years back started a project called Diamond Project. This is called hub and spoke model. And since I was involved in that, so I know that in detail. And this project is still going on. And so they have identified 4 major centers, which includes in each part of the country. And then the number of other centers around them. Like in the Northeast, you have centers like in Guwahati, you have the centers in the, I think this Silchar, that center is there. Similarly, the South as well as the Western part of India, and they have given the grants so that all the 3 tests are done free of cost to also anybody can send their samples to these centers and can get the test done free. So at least you have a standard diagnosis. So that is the second point, which I thought was very important. And once this is done, then obviously to follow the standard protocols. Unfortunately, as Silpa ma'am was saying, that the cost can go very, very high. Not all patients the cost will go so high. I mean, some patients, especially if they are in early stage or stage 3, if you treat them the standard protocols, your results are still very good. Unfortunately, like if you go from government hospital to corporate hospital, the cost can vary like a huge amount of variation, because the people will start following some new drugs have come in the market where we don't even have the long-term follow-up. They will say, okay, the results are very good, we'll go. Patient, they feel, okay, this is better result, then better go for it. And then suddenly they start feeling guilty, the family members, that I cannot afford that much of the cost of these new drugs. And obviously, all new drugs are going to be very, very expensive, these monoclonal antibodies and new targeted therapy, etc., etc. But not necessarily that they are going to be superior in long run. So we really have to follow the protocols which has been internationally accepted. And so we should insist on them. So this is the government regulation that all hospitals should follow a standard protocol for a given stage with minor variations rather than simply just going left and right. So that is the thing. And obviously the availability of the drugs, and a lot of drugs which are generic drugs available, that really has brought down the cost to a certain extent, and especially the hormonal therapy, cytotoxic chemotherapy, so which really help us, all of us, to treat many of more patients than what we used to do earlier. Then the other thing I would say, the telemedicine is something now India, we should be using it more often. Especially the follow-up is another aspect which you often forget. Many times patients complete the treatment, they don't come for follow-up. So if one can continue to keep them in the follow-up, at least you can pick up the relapse if at all happens, then much earlier, and then you can treat them. So you can get in connected with the local physician who can help us. And now with so many organizations around, like Dr. Dipjyoti said and others said, that one can find out the people in that area, and then those patients who are coming to the bigger centers, Delhi, Bombay, or Chennai, and then those patients, when they go back to their hometown, they can be contacted on the phone. So that I think we should really explore and develop a program so that we can keep a track of these patients, how they are doing, what are their long-term side effects, if at all, if there are any. That is something. The other thing I would say, like for many times, I mean, it's not so uncommon. We do see in our practice many patients who are very, very advanced. and the disease really progressing. And so one has to consider the quality of life at that stage. Unfortunately, many colleagues do recommend them the very expensive treatment that if you take this, you will get, they get the impression that they will get cured. So at that point where you really feel that the disease really spread in all parts of body, so your goal is something different. It's not really that you are looking for a cure. So which unnecessarily brings down the cost, takes the cost very high. So if you can develop some simple protocols for these patients, what we call oral waste therapy, so which can be given at home among the family members when they are around, that really bring a lot of solace to these people. So that is something which we really have to practice. And of course, we have to keep on requesting the higher people, Dr. Urbasi and the government and the other people, that the cost of all these drugs, even though this is still better in India than many other countries, but it's still quite expensive and beyond the reach of many people. So we still have to make effort that we can bring down the cost. So these are some of the points I would say.
Thank you so much, Dr. Lalit, for bringing out all these very vital points into the air and into the picture and focus of all the audience that is watching from all different spaces. Thank you so much. Sir also helped me prepare for this session beforehand. He pointed out all the vital notes that I would require around this space. So, sir, thank you so much for that as well. We will come back to you. Before that, I have another question for Shilpa ma'am. So, ma'am, as you have been informing us that there is this health claim rejections aspect, which is very big, and also the pre and post reimbursement aspect that most people are not really aware that they need to file it again and stuff. So how can we have this sort of ecosystem in which you are organizations such as yourself is working directly with the health insurance aspect or the consumers or the doctors, without having the patient to come to you separately for when they are faced with trouble? How can we generate that kind of awareness or integration between all different companies all together, so that the patient in the end is supported, does not have to run from one organization to other to seek help and support, and all things are just covered under one umbrella? So how can we achieve that, and what are the hindrances that you feel that might come up in this kind of process?
So we have already developed an app based on our experience of 5 years, where if a customer uploads the policy, it will read the policy and give you a summary of what all coverages are there. Of course, we need more policies so that the artificial intelligence is enabled and we are able to give more information to the customers. We are trying to do that. Our major hindrance is the reach. People are not aware that somebody like Insurance Samadhan exists, though we were in the Shark Tank as well, but still reaching out to entire India, to the people who first have a policy, insurance policy, which is only 6% coverage in India as of now. Only 6% population has the policy. Then they should have a problem and the claim should be rejected. So it's for us, reach is becoming very difficult. How to reach? You can't burn money, in marketing to reach to people. So we are trying also to connect with various communities. We are reaching out to hospitals as well to make awareness to the doctors, to the TPA desk, to the insurance desk in the hospitals, that if somebody is facing a problem, reach out to us. We may be able to help. If it is a genuine claim. Sometimes people buy insurance after having the problem, then we cannot help. But if it is a genuine claim and we feel that it's wrongly rejected, we have a success rate of 80%. So, and we are also trying to reach government bodies as well. If the government, schemes can be integrated into our application, and we can help the people in the rural area and people who are not much aware about their rights to come through us. And we can help them file the claim cashless, or pre-post. So pre-post also we have in the app, which guides you how to fill the the form and how to avail the pre and post. All these services are free of cost. We only charge once the claim comes through. We do not charge anything to the customers. Once the claim comes through, he gets the money in the account, then we charge 12% plus GST, which is our success model. So we work on success model. So people can reach out to us to understand what are the benefits under the policy. We will be happy to answer. They can reevaluate the rejection with us. It's free of cost. We are not charging. So if we feel that, okay, we can help, we will definitely help. So there is a win-win situation in the market that, you just try once.
Thank you so much, ma'am, for explaining that. Before we let you go, we have another question for you, just a follow-up question. So, as we hear so much that cancer care is expensive, while we're looking at health policies and people that are approaching you, what have been your experience in the top 3 expenses when it comes to health-related diseases, and where does cancer lie? And if you can help us narrow it down to, in your experience that you have seen with all these clients, where does breast cancer lie? Approximately.
I will not be able to tell you how much breast cancer has come. So our system classifies cases into cancer and heart and other stuff. So we see a lot of rejection in the cancer space because here the insurance company has to regularly pay. I mean, it's not a one-time operation and then they are through. So the customer are facing rejection in the first go itself. I mean, they are trying to find out anything. It may be a simple like you did not disclose a thyroid or some report from past they will get, and then they will reject the claim at the first go. That's what we are seeing, especially if the policies are new, like within 2 years, within 3 years, they try to reject because it's a long-term expense for the company. There is a relapse that may happen. So they are trying to reject. We are seeing rejection of oral therapies. We are seeing rejection of late usage of latest technologies, as I said, robotic surgeries or modern therapies. If the doctors are exploring in stage 3, stage 4, these are getting rejected. So that's the experience that we have. It's very limited as of now. We still have to go ahead and help.
We just needed a brief outline, ma'am. Thank you so much for putting it out in the light. Thank you. My next question is to Dr. Dipjyoti Das. Sir, you were talking about the model of distributed cancer care. If you can help us understand a little bit of that, and if that is specific to only Assam state, or is it applicable in other states as well, and if other states are also able to adopt this model for cancer care in their specific states. Can you please help us out?
Yeah. So, Dr. Asawari, thanks for the question. So, basically, since we are part of Tata Trust, so Tata Trust is coming up with similar initiatives in collaboration with governments, various governments. So, we are having a similar hospital at Tirupati, which has been set up with the joint collaboration between Tata Trust, Tata Cancer Care Foundation, and your Tirumala Trust, and also Andhra Pradesh government. That was one. Similar hospital also came up with Ranchi. One more hospital is coming up in Maharashtra, and the majority of actually the hospitals are coming up in Assam, basically because Assam government was very much basically encouraging towards having this type of a cancer care model in the Northeast. And also one of the reasons why it came up in Northeast is basically because of the high incidence of cancer. We have seen that almost all the cancer patients earlier used to go to either Mumbai at TMH Mumbai or TMC Kolkata or maybe CMC Vellore or Apollo Chennai, etc. That's how has been the flow. And even if you see the trains actually that were going to Chennai or Mumbai, they were all maximum of the patients are all cancer survivors only, or they are either going for treatment or follow-up or something like that. So I think that was one of the major challenges, and our current CM actually was also the health minister. So that way he actually was able to identify this problem, and that's how actually he came up with the solution. And before actually ECSAFE came into the picture, Assam had got only 5 actually cancer hospitals, and among those 5 also only 2 were government setups which were catering to cancer patients. So overall, if we look at actually the requirement, only if I talk about Assam, so Assam has a population of around 3.6 crore. So, and usually it's recommended that 1 LINAC is required for at least 10 lakh population. So that way also we require at least 36 LINACs for a population of Assam. And before ACCF came into existence, we had got only 3 LINACs in the entire state of Assam. And if I talk about Northeast also, then Northeast also didn't have much facilities. People usually used to come to either Guwahati or maybe to outside Assam. So that way, if I took the entire population of Northeast also around 5.4 crore, then the requirement was of 50 plus LINACs, and whereas we had got only 3 or 4 LINACs. So that way the gap was huge actually in terms of the requirement of infrastructure. I'm just talking about LINAC, but if I talk about other people also like oncologists, the doctors, that was also huge. We didn't have a single actually brachy facility in the entire Northeast. There was one at B. Barua, but that was also non-functional for last 1.5 hours. So with the coming up of ACCF, we are able to actually start brachy facility in all our 7 centers. Again, you know that brachy is something very, very important modality of treatment for cancers like cervix, etc. So all those things actually came up because ACCF actually came into the foray. And this model is also very important because what we felt is that just having hospitals is not enough, because we would not like patients only to come to the hospital at maybe 3rd or 4th stage and get treated. More important is also the screening, whether we can do some intervention at the community level also or not. So that's why we came with this 4th wing also, that is the outreach team, wherein actually we were trying to do more and more outreach activities in terms of screening, in terms of awareness, etc., etc. And that's how actually we were able to actually basically bring cancer care with this model. There is another tie to it. Along with these 4 things, we are also coming up with a South Asian Cancer Research Center in Guwahati. So this will be one of a kind actually cancer research center, a 800-bedded facility, which will be totally dedicated to fundamental cancer research. So that way we are actually able to close all the gaps that are required in terms of cancer care. It has to be cancer treatment, it has to be awareness, and also cancer research also has to be an integral part of this overall scheme of things. So we are coming up with that also in the next 4 or 5 years. And again, I think we were talking about cancer awareness. I think Urvashi madam also touched about stigma, fear. So what we have felt now is that cancer actually means what we have done is in the last 1 year, we have at least had around 1 lakh footfalls in our hospitals with around 40,000 radiation sessions and at least 20,000 chemo sessions in our 7 hospitals in last 1 year. But what we have seen, a major problem is that though we are doing awareness also, but many times awareness don't translate into actually better outcomes. And that may be because of the maybe non-compliance in attitude of women after breast cancer screening also, because maybe they may not like to go for diagnostic follow-up for their abnormal findings, even though we have told them that there is an abnormal finding in the screening, but they may not like to actually go for a diagnostic follow-up, maybe in terms of a mammography or something post their screening, irrespective of their economic status. That is another important thing. And maybe this suggests that factors like fear, stigma, or discrimination, denial, or are some of the important areas actually that needs to be addressed, as I think Urvashi madam was rightly pointing out. So along with awareness, the community related this particular aspects also needs to be actually taken care of, because this is also something very, very important. And since Urvashi madam is there, so I'd also like to actually tell through her and request her that right now actually what a major problem we are facing was that we didn't have a proper cancer registry, where we are not able to really identify the occurrence, the prevalence, and other things, because cancer is still not a notifiable disease as per the as per Indian government laws, whereas there are a few other notifiable diseases like malaria, dengue, those are notifiable. So if government actually helps to maybe designate cancer as one of the notifiable diseases, then it will really help us in terms of getting really good data, wherein we can actually have better policies, better actually initiatives in terms of addressing this thing. So this is one of the things maybe I would like to actually request through the channel of Urvashi madam, because she is here only. And again, if something like if we have something like a dedicated cancer cancer control program, because till now cancer care program in India is part of NCD only, NCD program, non-communicable disease program. But if we have a separate dedicated program like National Cancer Awareness Program, then I think it will bring a lot of more focus to this whole management of cancer. So I think these are the 2 of the points that I'd like to take through your forum. Yeah, thank you.
Thank you so much, Dr. Das. Yes, my next question is the same question to Dr. Urvashi, ma'am, if we have you with us. If you can please talk about a little bit on how can, we have cancer as also a notifiable disease. What are your thoughts on the same?
Yeah, I mean, I think there is a huge case for that, and especially with the numbers now going up considerably, across different types of cancers, across states. So I think definitely, this is something that, should be and is being looked at. So I think that is definitely one aspect. But also, I mean, I think, the registry, etc., was mentioned. So I think at least from Niti Aayog's perspective and, more broadly also the central government, we have been working a lot on, digital health aspects and, health records, linking it all up with, the background and the history, the medical history of patients. So all those kind of things, there's a lot of work happening. But again, it's very difficult and challenging to, roll out in a country like India. Because it's not just the center which can, just decide all this. I mean, the fact is that health is still very much a state subject. So anything, any decision of consequence, and more so its implementation, depends on the states. And so a lot of it is not just, dependent on the central government. So I think that is where a lot of the operational bottlenecks and challenges need to be addressed. And, the implementation can only be improved in that manner. But also, I think, obviously issues like insurance package, at least under the Jan Arogya Yojana, so at least under Ayushman Bharat, I mean, we are constantly looking at it. We're constantly trying to see how we can revise it. What are additional treatments that can be included? So, I mean, that is all, I think it's all work in progress, and, that will all keep happening, revisions will happen in due course. But I think it's more important that, whatever, even the basic commitments that we are making, the basic package also that we are committing, we at least deliver on that, because still in a lot of parts of the country, access to those kind of services is still limited. Even something like chemotherapy, people still in many parts are traveling long distances to even get access to chemotherapy. So I think we need to really sort out, those basics as well, along with, of course, looking at how we can improve and further add newer treatments and, all of that. So I think both those things need to happen, simultaneously.
Thank you so much, ma'am. Thank you for the information. My next question is to Mr. Ajay. Sir, we have been discussing different aspects of how Arogya Finance is helping people, not just breast cancer, but also cancer and other diseases as well. So while your experience with the organization, what are the various challenges that you have faced? Do we have? Yes, we have Mr. Ajay with us. So what are the various challenges that you see, in this process of providing this sort of loans to the people and for them to access it? And also we would like to understand the need specifically around financing for cancer, as we are discussing the cancer space and the equity. So what has been your views on the same?
Yeah, so as a fintech organization and BFC, we have already onboarded around 2,400 plus partners. There are various medical devices companies, hospitals, clinics, distributors, etc. So we are not specifically going into the clinical aspect of whether that therapy is required, as mentioned by Dr. Lalit Kumar. But however, if that therapy is acceptable to a family member, to the HCP and to the patient, then in those specific cases, the challenges what we face, the first is that the family member typically tries to avoid this high cost or innovative treatments if they are prescribed to them, because they treat it as a financial burden on their families. And the patients often opt out of these therapies, which results into a lower compliance and suboptimal clinical outcomes for the patients. So that is one thing we observed, that they don't avail the full therapy regime. The hospitals, they struggle because there is a lower success rate because of lack of therapy adherence, and the kinds of the pharma measures, they would have their global research done, and they would have introduced this specific successful medicines or genomic test in India, and they want to scale this particular medicines or tests. They are not able to also scale because there is no finance available, because as in Indian context, we are underinsured, and those who are already insured, they have taken a very low level of insurance. Like even in case of our Pradhan Mantri scheme, like a 5 lakh rupees health insurance cover is available. But for the middle class, even if they are taking a cover, it is lesser amount. Okay. So in such situations, what we find is that if cancer becomes a notifiable disease, and if we get support from the state government to reach out to those specific therapies and for specific hospitals, it will be a really a win-win situation for all stakeholders.
Thank you so much, Mr. Ajay. And another question we have before we take the key takeaway messages from all panelists is to Dr. Lalit. Sir, or it's an open question as well. Dr. Dipjyoti can also answer depending on the understanding that not just cancer care and treatment, but we are trying to prevent cancer for the future generations. There are so many organizations that are coming up with AI and ML models for predicting cancer, etc. And also the various aspects of typing, etc. So what more is required when it comes to research in the cancer space? Do you feel that there are any particular aspects when it comes to cancer research that need to be looked at in detail, a certain type of studies, a certain type of area, whatever you have identified in your experience with cancer? And if there are any ideas that you would like to bring forth so that all the viewers that are watching can take pointers from that and work towards those areas, so that we're not only just fixing what has already happened with the people right now, but also able to predict and reduce the prevalences for future generations through research.
Right. There are two important areas in this regard. One is from the diagnosis point of view, like the pathology slides. So already number of papers have been published, and some centers are routinely following, like in the abroad, like Memorial Sloan Kettering. So basically, so you have the database of many thousands of pathological slides, and you have defined a pattern. So by using this artificial intelligence, one can really make a diagnosis. So you don't really have to don't have to go through the all kind of vigorous thing. You can make a diagnosis what subtype it is and all that. So that is still, I would say, not sensitivity and specificity almost 90%, 91% kind of thing. So they're still sorting out. You have to have the centers, and some centers in India probably are in the process of learning these things and maybe able to do the thing. And same thing is happening in the mammograms. So reading mammograms rather than by technical staff, like, so once you train them, then this can be read and then can be reported on time. Only those which are very doubtful, then they can be kept for the senior people. So that way you can really take care of the limitation of the experts, which may not be available at many centers. So that these are two, I think, area, at least from breast cancer point of view.
So if I can add, Dr. Asavari, to what Dr. Lalit has said. So at ACCF, Assam Cancer Care Foundation, what we are doing is we are having a tie-up with QRI. So QRI is one of the AI platforms, which helps us actually in terms of finding out lung cancer cases through X-ray films. So we run the X-ray films through them, and then it says that it has a 99.9% detection of lung cancer, which may have got missed through a radiologist. So based on that, we have been able to identify 6 to 7 cases in the last 5 to 6 months in the early stages of lung cancer. And post that, again, we go through the routine process of actually doing a CT also and the other routine things of a biopsy, etc. But then that is a very important tool that we have come across. Other than that, not just for diagnostics, but we're also using tools like Navya platform, which is again an AI-based platform that helps in your tumor board meetings actually. So since most of our locations are very much far away and few of the centers are having very less number of doctors, so it may not be very prudent to have tumor board meetings because we don't have all the doctors. For example, we don't have a surgeon in our L3 centers. But then with the help of this AI modulated Navya platform, the doctors are able to request their queries for a AI-based tumor board setup, and they get their basically answers within 4 hours as per the defined timelines through this AI platform. Other than that, also what we are trying to do is we are also trying to actually help and use technologies like your telepathology. We are having scanners actually for the slides, and we are using that also. Right now we are having 2 such scanners. We wanted to actually use it as much as possible. We are trying to do a tie-up with TMC Kolkata also in this regard. So all these things actually we are currently doing in order to actually leverage the various technologies that are currently available. Because again, as an organization, if we don't actually leverage the existing technologies or the upcoming technologies, then we will not be able to maintain the competition. And again, I think this type of technologies also will help us to bring I think quality of cancer care at a much better level, and also will reduce the cost. I think similar type of actually AI based technology also needs to be used for actually on point of care testing, actually the screening that we are doing. So that also needs to be actually leveraged. So I think these are a few of the areas that needs to be looked at. Yeah.
Thank you so much, sir. We had similar few platforms in our previous editions of the same edition, but previous episodes who were working for, this sort of oncology space, screening, early screening, etc. And those were Niramay and OncoStem. So they are also specifically working into breast cancer space. And we can go on and on discussing this aspect because technology and healthcare is the future. There are endless questions and endless answers to all. So without, taking much of the time, as we are nearer to our end of the discussion, I will take very quick takeaway messages from all our speakers, starting from Dr. Lalit Kumar. Sir, your key takeaway message for all the viewers that are watching as we are commemorating the Breast Cancer Awareness Month.
So I would say that making an early diagnosis, timely treatment, and following a healthy lifestyle and regular follow-up, I think these will be some of the key points for the successful outcome.
Thank you so much, sir. Dr. Dibjyoti, sir, your thoughts, your key takeaway message.
I think the problem needs to be actually looked at from a more holistic perspective. I think an assessment of existing levels of cancer awareness, I think, is one of the most prerequisite actually for planning any comprehensive healthcare program around breast cancer. Again, it will include early detection, treatment campaigns, and many more things. So we need to actually urgently explore the drivers of awareness deficits, because there are a lot of awareness deficits currently. The stigma surrounding breast cancer, both in general population and even I have seen among healthcare workers also, it's there. So I think all those things needs to be taken care of. Then only actually we'll be having a such successful campaign against breast cancer.
Thank you so much, sir. Ms. Shilpa, ma'am, your key takeaway message for the viewers that are watching.
It's early detection, which is most important. Have an insurance product in your kitty. Know the insurance policy. If you have any doubt, you can reach out to us. And if any claim is rejected, reach out to us for a re-evaluation if something can be done about it. That's all.
Thank you so much, ma'am. Very precise. Mr. Ajay, please, your key takeaway message.
Yeah. So a more awareness about Care Now, Pay Later options by various state and central government agencies can make Arogya solutions available on tap for patients and their family members. So we'll look forward for those kind of associations. Thank you.
Thank you so much. With that, we wrap up this super interesting session on the topic of breaking down barriers, ensuring equity in breast cancer care, which was the part of Breast Cancer Awareness Month series. Thank you so much to all our panelists for taking out time from their busy schedule and imparting us with wealth of knowledge and information. We thank Dr. Urvashi Prasad, Dr. Lalit Kumar, Ms. Shilpa Arora, Dr. Dibjyoti Das, and Mr. Ajay Varze for taking out time and imparting us with so much information on this topic today. Thank you so much. We would also like to thank our partner, Novartis, in this brilliant initiative for raising awareness around breast cancer. Thank you so much. And we would also like to thank all our viewers for staying with us till the very end. I hope the session was as insightful and informative it was for you as it was for us. With that, we sign off now. Stay happy, stay healthy. Thank you.